Hello, I'm Sandro Galea. I'm the Dean of School of Public Health at Boston University. I'm here broadly to talk about health as a public good. But before I start, I would like to begin by talking about firefighting. The traditional role of firefighting, which dates back to the Roman era, has been, unsurprisingly, to put out fires. More recently, however, the focus has been on fire prevention. In the US, starting roughly after the Great Chicago Fire in the 19th century, fire departments have helped communities adopt strategies to stop fires from breaking out. This generally involves a combined approach of building safer houses, creating a culture of prevention by educating the public on safety best practices. These efforts are funded by the communities themselves. We have come to see them as a public good. Public goods are resources that benefit everyone and are sustained by collective investment. They include parks, public schools, fire stations, national security, the highway system, and the environment. When we call something a public good, we have decided it is too critical to be accessible only to those who can pay for it. We then take steps together to ensure the resource is widely available. When it comes to fire prevention, this investment has paid off. In 1977, there were 5,865 civilian deaths caused by home fires in the US. In 2016, there were half as many, 2,735. The example of firefighting seems apposite to the present moment. We are in the middle of a global health crisis that has effectively lit the world on fire. It has now been about 4 months since COVID-19 first entered our consciousness. During that time, it has spread around the world, threatening the physical and mental health of populations. At the same time, the physical distancing measures we have adopted to slow the spread of disease have created social and economic disruptions that will likely be with us for many years to come. Our response to COVID-19 has been uneven. Some countries have done better than others at slowing the pandemic. In the United States, the federal and state response has been patchy, with some good decisions but also many stumbles. In a sense, our vulnerability to this pandemic was sealed long before the disease emerged. COVID-19 has exploited existing health disparities, using the poor health of vulnerable populations to gain a foothold. The conditions of poverty, racism, lack of healthcare access, and other factors that produce poor health in society have made some people far likelier to catch the disease than others. It is not exactly news, of course, that these conditions undermine health. So why have we so long accepted them? I would argue that the central reason is we have not been seeing health as a public good. Instead, we treat health as a commodity, something to buy and sell. We have come to see health as healthcare, as the doctors and medicines that treat us when we are sick, rather than the state of not being sick to begin with. Because of this, the vast majority of our health spending has gone to creating new drugs and treatments. This individualistic approach would seem crazy if applied to firefighting. Imagine charging to put out a burning building. Yet when it comes to meeting the equally urgent need of addressing poor health, we have taken that very approach, putting a price on what should be a public good. COVID-19 has, to my mind, exposed the limits of this approach to health. It has shown in a visceral way that our health is linked. Your health depends on mine, and mine on yours. Those of you who have been quarantined with others likely know what I mean. Our thoughts about our health are now intimately tied to our thoughts about others. It matters greatly how they feel, where they go, whether they have the resources they need to be safe and healthy. Because if they cannot be healthy, we cannot rest easy in our own health. We need to act collectively to ensure everyone can access the resources necessary for health. This is what it means to see health as a public good. It is worth noting that the steps we have taken to mitigate COVID-19 have had little to do with medicine. This is because medicine, for all its uses, has little bearing on prevention. Doctors and drugs can help us if we catch COVID-19, but our overwhelming focus these past few months have been on not getting the virus at all. In order to prevent COVID-19, we must create the conditions for keeping it at bay. This has meant addressing the disease at the level of the conditions that shape health. These include economics, employment, community networks, race, how we treat older adults, and the physical layout of our communities. These steps represent the right approach to health, one that points towards health as a public good. They are also at a remove from how we typically address health. We have hesitated to see health as a public good, I suspect, because of what doing so would mean. It would imply a responsibility for addressing health at every level of society, for building a world that generates health. It would call on us to place health at the heart of policymaking, industry, urban design, even geopolitics. COVID-19 has been a reminder that disease does not respect national boundaries. This makes pursuing health as a public good a transnational project, with countries working together to build a healthier world. It also means acknowledging that everyone has a right to health. A world where any number of people are consigned to poor health is unacceptable. COVID-19 has reminded us that the health of the few is tied to the health of the many. We need to take steps to support the health of the vulnerable. We have already begun to do so in response to COVID-19. In the US, for example, the federal response has included direct financial assistance to Americans. We have also seen a new focus on the populations most at risk of the disease, including the homeless, low-wage workers, and older adults. The question we now face is, will these be stopgap measures limited to the duration of the pandemic, or will they be the start of a new approach to health? The past few months have shown what we are willing to do for health when we feel it is at risk. We have transformed the world with dizzying speed. Those who think investing in health as a public good is too ambitious need only look at what we have done since mid-March to see that we can accomplish what we feel health demands when it demands it. Now imagine what those months might have looked like if we had chosen to treat health as a public good well in advance of COVID-19. Imagine a Marshall Plan for economic justice that created a job guarantee and basic income for all citizens, so that no one had to break social distancing to risk going to work. Imagine cities designed to end the residential segregation that creates pockets of poor health like asthma, which drive COVID-19 risk. Imagine a system for older adults that truly integrates them into the community, where their health is a matter of collective care. How much healthier would we be in such a world? Certainly, COVID-19 would still pose a challenge, but would be lessened by our own commitment to treating health as a public good. There are, of course, trade-offs to this approach. There is something comforting in thinking health is just a matter of buying the right drugs and seeing the right doctors. But this is an illusion. We have tried this approach for years and been consistently ill-served by the results. COVID-19 is in many ways a culmination of this. Treating health as a public good will mean de-emphasizing our individualistic approach to health. Eventually, this pandemic will end. But the threat of pandemics will remain ongoing. In some sense, we have been lucky these past months. While any sickness is a tragedy, any death one too many, this pandemic is not the worst case scenario for such an outbreak. The next outbreak, and we know there will be one, could well be deadlier and more infectious. Whatever form it takes, it will be helped along by the same conditions that helped COVID-19 if we allow them to persist. Ending this vulnerability means accepting the trade-offs and addressing health as a public good. Thank you for having me.